സാധാരണ നമ്മൾ ഹോസ്പിറ്റലിൽ എല്ലാവർക്കും അറിയാൻ പറ്റുന്നൊരു കാര്യമാണ് ICU. ഇത് വളരെ ഫെമിലർ ആണ്. ഈ ഡിപ്പാർട്ട്മെൻറ്റിനെ കുറിച്ച് നമുക്ക് സാധാരണ എല്ലാ ഹോസ്പിറ്റലിലുള്ള ഒരു പ്രധാനപ്പെട്ട ഡിപ്പാർട്ട്മെൻറ്റായിട്ട് നമുക്ക് കാണാൻ പറ്റും. ബട്ട് ഈസ് PICU. PICUയെ കുറിച്ചാണ് ഇന്ന് മെഡിട്രാക്ക് ഡിസ്കസ് ചെയ്യുന്നത്. PICUവിൻ്റെ റോള്, അതിൻ്റെ ഇമ്പോർട്ടൻസ്, അതിലെ ഫങ്ഷൻസ്, ഈ വിഷയമാണ് ഇന്ന് ചർച്ച ചെയ്യുന്നത്. ഈ വിഷയത്തെക്കുറിച്ച് കാസർഗോഡ് വിഷൻ്റെ പ്രേക്ഷകരോട് സംസാരിക്കുന്നത് മാംഗ്ലൂർ AJ ഹോസ്പിറ്റലിലെ പീഡിയാട്രിക് ഇൻറ്റൻസിവിസ്റ്റ് Dr. Akshitha Shetty. Ma'am, welcome.
Namaste.
See, ma'am, normally in hospital we have seen ICU. See, common people, they know that what is ICU, what are the functions there. See, okay, what are the importance of ICU. Then there can be PICU. See, actually, what is PICU?
So basically, as you told, like we all know about ICU. So PICU is Pediatric ICU. So it is a dedicated ICU area where only kids are kept. So where we monitor 24 hours the very critically ill children. So basically it is similar to adult ICU, but in adult ICU if we mix with pediatric, the infection can spread everything. So that is why we have a dedicated pediatric ICU where only pediatric kids will be kept.
See, ma'am, what are the difference between pediatric ICU and ward? In ward also we are admitting children.
Yes.
And what is the main difference between these two?
So the difference is between the staff nurses, the like protocols what we follow in ward. Basically what happens is in ward we have 5 patients and 1 nurse. But whereas in pediatric ICU we have 1:1 nursing or 1:2 nursing. So every 1 patient dedicated 1 nurse will be there, or for every 2 patients dedicated 1 staff nurse will be there. And we have 24 hours monitoring system where there is continuous monitoring which happens, and we have 24 hours doctors who will be just in the ICU to monitor the kids, and the ventilators, the machines what we use, the procedures we do, which we cannot do in the
are there,
yes, and which we cannot do all these procedures in the ward. So we have to shift to the PICU for this thing.
Okay, see, ma'am, what kind of children are admitting in PICU?
So basically children with fever, cough, who comes with breathing difficulty, and basically with high grade fever if we see the baby is not maintaining blood pressure, or the most common reason is with fever they can have seizures in the sense fits kind of stuff, or some children with developmental delay having continuous fits, or when we are planning to give some medications like immunoglobulin, rituximab. These are the medications which we cannot give in ward because it has to be supervised. So that is why we shift to pediatric ICU, and some sick children who requires other technologies like ventilation, and who requires like procedures to be done, those kids are admitted in the PICU.
Okay, naturally common type of emergency have seen in PICU. What are the common type of emergency?
One is like main commonly we see pneumonia children, then septic shock children, and we see cardiac disease children, and even we see post-operative care like post appendicectomy, post any major surgery, they will be shifted to PICU for monitoring. So we have a good cardiac team who operates on ASD, VSD. So post-op they will be shifted to PICU, and we have seen something called as febrile seizures, most commonly which we see. Those children will be monitored in the PICU. So these are the thing, and road traffic accidents or fall from height, these are the kids who needs monitoring in the PICU.
Okay, see ma'am, what are the facilities we are providing in PICU, especially in AJ HRC?
Yes. So basically in AJ we have a 24 hours monitoring system here which will be recorded and which will be continuously. Suppose we have to go back and see what are the vitals, we can always go back and see. So we have a multidisciplinary team here. We have a high-most ventilators which is available with advanced technologies. We have EEG monitoring for children who comes with fits. We have high frequency oscillatory ventilator, we have non-invasive ventilator, we have HHFNC, we have CPAP machines, so we have dialysis facilities.
Excuse me, all these facilities in PICU,
yes.
For example, ma'am just spoke about IG, this one, what EG system, then that one also in facilities in PICU?
Yes, it is in PICU itself. So we will keep these children in PICU only, nowhere else, so that these facilities will help us to be more aggressive in management, and we'll know accurate things when what is happening.
See, regarding ventilator also ma'am mentioned this, see children how it is using ventilator, what is the contribution of ventilator in PICU?
So in last few decades, ventilator has improved the survival rates a lot because children have a very higher capability to recover. So generally there is a myth that once people go into ventilator they will not come back, but it's not like that in the children. So when we have this advanced ventilatory systems, we have seen children whom we have removed from ventilator and they have improved. So this children's like we can't use adult ventilators in children. So we have a dedicated pediatric ventilators for this much weight what ventilators we have. So we have all kind of this ventilators and we will do settings based on the age of the child, weight of the child. So that is very, very important here.
See, ICU itself is some emotional bystanders are there, especially in PICU. That degree of that person it will increase. Then how it is communicate with the parents? That inside the patients, the children you can manage because the team is there. Then how to handle, how to communicate with
it's
parents?
a very difficult thing because what happens is here parents' emotions are involved here. So and they will be more this thing about their kid what is happening. So what we do is we do counseling sessions regularly. So we take them in confidence. We exactly tell them what is the scenario, what are the possibilities which can happen. So we tell them what are the positive things which can happen, what are the negative things which can happen, and in next 24 hours what is the update. So every day we do twice, twice counseling we do for the updating the vitals or the condition, the severity. We won't give them false assurances. We will tell them what exactly it is, and we respect their emotions and we value that, and that is where as a pediatrician's role is very important.
See, till what age, ma'am, in pediatric ICU admission?
See, from 1 month to 18 years.
Up to 18?
Yes, up to 18 years. Previously it was up to 15-16 years, but now we are giving more importance to adolescents also. So up to 18 years we manage in pediatric intensive care.
See, ma'am already mentioned about the facilities. See, according to it's a teamwork. ICU is a teamwork. See, in that team, what are the experts or technology doctors? What are could you please explain that?
Yes, so as I told you before, it is a multi-team disciplinary team what we have. So we have a senior pediatric intensivist with us. We work as a team. We have a pediatric cardiologist, we have a pediatric endocrinologist, we have a pediatric gastroenterologist, we have a pediatric cardiac intensivist. So we have an infection care team who comes and do surveillance regarding our infection care, and we have a social worker who help in counseling and whatever social issues they are facing. So basically it's like almost we have an entire thing. We have a pediatric nephrologist as well. So we discuss as a team what is our plan, and while counseling also we involve all the doctors. We sit together and counsel. So all of us are in the same terms.
See, regarding counseling with the parents is that we have already told or discussed today. See, what are the other challenges especially doctors are facing in PICU?
So the challenges are like since ours is a tertiary PICU care, we get delay referral cases. So already the child is very critical. So managing that is very difficult and counseling them. So that is one very important thing. So we usually tell the referring pediatricians in the rural areas refer early. So early referral helps us to get more like we can pick up things more and we can do aggressively, because when they come in the last stage it would be very difficult for us to. So these are the one commonest difficulties what we are facing in pediatric intensive care.
See ma'am, in PICU, in your experience, any rare experience from this side?
Like rare experiences that like there are few cases which we thought like almost like they are at the end of like septic shock with ventilator, like very high settings with ARDS what we call it as. So this child was not maintaining saturation, just 87, 88, completely white out lung. So we ventilated, we put the child on prone ventilation. Prone is we make the child lie prone position so that the ventilator effects are more during that position. So almost 10 to 12 days.
What is the age of that?
8-year-old.
Okay.
So like 8-year-old parents were also very anxious. So we could extubate the child after 12 days and we put on the non-invasive support and gradually things got better. We discharged the child also.
Okay.
So
Recently, there is a
yes,
case
recently, a month back this happened.
Yeah, correct.
So that is like we feel very happy when the children go home.
Yeah,
like that.
correct. Okay, ma'am. So in AJ, HRC, PSU, what are the facilities and what are the advanced technologies in PICU?
Yes, we have high frequency oscillatory ventilation. We have all newer modes of ventilation. So we have non-invasive ventilation. We have HFNC. We have CPAP machines. We have dialysis option. We do peritoneal dialysis also. We do EEG monitoring. We have continuous advanced monitoring systems like temperature recording, continuous temperature recording. So these are all the very much like facilities, especially here what is available.
See ma'am, we have already discussed and new updation about PICU. See, anything else new, any new technologies we are expecting, like because robo is coming nowadays.
Yes,
Okay,
yes.
like that, any other new technologies
So
coming
nowadays
in PICU side?
artificial intelligence is playing a very important role. So we are like AI early warning system is something which is coming up. So that AI senses that this child is going to get bad, like by monitoring the vitals and all that. That is one thing.
Yeah.
Second thing is ECMO, which is already there. We are doing it quite frequently in other this thing. So that is also one of the good. And for neurally adjusted ventilator, that is called NAVA ventilation. So that is for children who have CNS involvement. It helps in a better way to extubate them, better way to sense their respiration. And we have something called tele-PICU also, which is coming up.
Yeah, it is already came.
Yes, it has already come up, and I think it is widespreadly going through all other parts of the.
It will get a good result in a rural area or those who cannot reach in hospital.
Yes.
There it is affecting more.
So as I told you before, delayed referrals are the ones which is
that
affecting.
we can avoid through this
So tele-PICU is in rural areas where pediatric intensivist is not available. So they can do video consultations with us and take our opinions to better manage, and we can sense that this child will not be able to manage there, and they can refer to us. And here we can see in video consultation what are the ventilator settings. We can guide them through all that.
Okay, then it will affect more in this way.
Yes, so that we can like they can refer properly, and proper treatment ensures in rural areas also.
Okay, ma'am. കാസർഗോഡ് മെഡിട്രാക്കിൻ്റെ ഇന്നത്തെ എപ്പിസോഡ് ഇവിടെ വൈൻഡപ്പ് ചെയ്യാണ്. ഈ എപ്പിസോഡിൽ കാസർഗോഡ് പ്രേക്ഷകരോട് സംസാരിച്ച മാംഗ്ലൂർ AJ ഹോസ്പിറ്റലിലെ പീഡിയാട്രിക് ഇൻറ്റൻസിവിസ്റ്റ് ഡോക്ടർ അക്ഷിത ഷെട്ടിക്ക് കാസർഗോഡ് നന്ദി അറിയിക്കുന്നു. ഒപ്പം എല്ലാ പ്രേക്ഷകർക്കും നന്ദി, നമസ്കാരം. താങ്ക് യു മാം.
താങ്ക് യു.